See if we can stay on time. Hi, welcome everyone. Good morning. My name is Tara, and I am an IDF staff. I actually work with the USIDNet program. I'm the director for that. So you heard a little bit about that in the opening session this morning with Dr. Cunningham-Rundle. So if anybody has any questions, you can always see me. Before we get started, I have a couple of things that I'm supposed to tell you. So bear with me. I'm sorry. Now I don't know what to do.
Give me all the answers.
Oh, no. Okay, I'm going to stand back here. Okay, here's the things that I need to tell you. It's about surveys. You should have received an email prior to the conference with a link to some surveys, and we thank you for completing the pre-conference surveys. And apparently there will also be post-conference surveys, so we want to hear your feedback. After the conference, you'll be notified through either the conference app, if you have it, and you'll receive an email as well. So thank you in advance for completing it. Your feedback, this is what I'm told, is absolutely vital as we try to understand the true impact of the conference. So thank you. Additionally, please be sure to create an IDF EPHR if you have not. We have kiosks out there. And through that, you can enroll in PI Connect, which would make me very happy because then you're allowing the USIDNet patient registry to use some of your data for research. So that would be great. It gives researchers a first-hand account of what it is like living with PI, and you can learn more and register at the kiosks. Questions will be answered at the end of the session unless you have other options. So I've given out question cards when you came in, so please write those down. We have a lot of time today, so I think we should have time. I'll collect them when it's time and hand them over to Dr. Torgerson, and then we'll get those answered. So now, without further ado, it is my great pleasure to welcome you to our session today, which is, I'm going to have to read this because it's a long one, Unspecified Combined Immunodeficiencies with Autoimmunity and Infection. Come on in. Welcome. I just said that this is the Unspecified Combined Immunodeficiencies with Autoimmunity and Infection session. So if that's where you're looking, you found the right spot. This session will be presented by Dr. Troy Torgerson, who I'm sure many of you heard this morning, a great talk on genetics. So Dr. Torgerson serves as principal investigator within immunology at Seattle Children's Research Institute, and he is also the associate professor in the Department of Pediatrics within the University of Washington. He's also a member of our IDF Medical Advisory Committee, so thank you for all that. Please join me in warmly welcoming Dr. Troy Torgerson.
Thank you, Tara, for that very kind introduction. So it's great to be here. So this is the session. So this is a new session this year. I met with Marcia and some of the other folks at IDF about a year ago. We sort of conceived this session, trying to think about patients who may have some additional challenges beyond just the usual infections that we see in many patients with immunodeficiency diseases. And my interest, so I'm trained as a pediatric rheumatologist, actually, is my training, but I see mainly immunodeficient patients. And so I've got a tremendous interest in autoimmune disease, in the basic mechanisms that cause autoimmune disease in the immune system. And so that's where a lot of my research and efforts have focused. And I've focused a lot, as I'll mention in a couple of minutes, within the immunodeficiency field, this whole kind of area around autoimmune disease, and now kind of what we're calling as a field, immune dysregulation. It's what we're kind of grouping all of this together, and that may be autoimmunity or inflammation is kind of emerging as not a major part of the field of immunodeficiency diseases, and we'll talk a little bit about what that why that is in a couple of minutes. But that's sort of the background. Now, that's a little bit about me. I would love, before I launch into this whole thing, to make sure, when we do these sessions, we sort of guess at what people are going to be interested in hearing, and we have some guidance, but I would love to actually hear what people are interested in hearing about, sort of specific general topics maybe that you were hoping to maybe hear today when you came to this session. So let's just take a minute, or you can just shout them out, and let me just sort of hear, and that will help me to sort of I can pick and choose through the slides to find things that are more interesting, and I want to leave plenty of time for discussion. So what do you want to hear about today? Do you want to hear about diagnosis? Do you want to hear about treatment? What do you want to hear most about? Diagnosis. Okay, so diagnosis, from the standpoint of if you've got this sort of mix of symptoms and you don't have like a specific diagnosis sort of thing, is that kind of what you're thinking about? Okay, all right, and we can talk about some of the approaches that we're using to try and do that. Yes? Okay, some of the autoimmune problems that go along with PI, and so that I did anticipate actually, and so I have some slides. We'll go through some of those. Okay, good. T-cell infiltration of liver and lungs. Okay, we'll talk a little bit about that too. So good. Complement disorders. Okay, I took out a couple of specific complement disorder slides. However, we can talk about those, and so we can talk about complement disorders.
My son has CVID, but I'm not being diagnosed.
Mm-hmm.
But they're facing chronic pneumonitis, how that is related.
Okay, so the question. So I don't know if everybody heard that. So is it okay if I share that? So she said that her son has been diagnosed with CVID, but she has now been diagnosed recently with chronic mucocutaneous candidiasis, or candida infections in the mouth, the throat. So it's thrush is another name for that, and so that's one of the things. And there's actually a specific genetic defect that we think of in patients who have that actually. So. Mm-hmm. Yep, so we can talk about that too. Other questions? Yeah.
I've been diagnosed with autoimmune neuropathy.
Okay.
So I'd be interested in knowing more about autoimmune problems within the brain.
Okay. Great question, and that's a great question, and I did not actually. That's the one organ system I didn't include in my things. Now that you mention it, so anyway, but we can talk about it. It won't prevent us from talking about it, but I didn't include any slides about that. But you're absolutely right. That's a good question. Yes.
Is there a relationship between dysautonomia and autoimmune?
A relationship between dysautonomia and autoimmune disease, which kind of gets to that question. Yeah, exactly. So we'll touch on that. If I don't touch on that, remind me at the end. Yes. Yeah, good question. So if you're currently on therapy, then are there still diagnostic things that are available? What's affected by being on gamma globulin and what's not, and are there some other approaches you can use to diagnose it? Okay, good. Anything else? That's a good list, actually, for starters. Yes?
I didn't exactly hear what she said, but is that how the PIs affect the nervous system and mental health?
So the dysautonomia is not so much the mental health piece, but it's more about it can be blood pressure issues, can be sort of chronic fatigue, chronic pain syndromes, but mental health is another part of that, and so yes, we can talk about that a little bit too. So. Okay, good. Well, that's quite a group of things. So let me sort of go. I've prepared a number of slides. I prepared more than we really need, just because then I can kind of pick through them and kind of get to some of the questions that you've raised. And so let me do that. And if you have questions as we go along, I would much rather answer questions kind of as we go, because, well, if we're on a topic and you have like a burning question that pops up, it makes a lot more sense to sort of address it while we're on that topic before we sort of move on to the next one, right? So please stop me. And if I feel like, the discussion's getting out of control and, I don't think that's going to happen, but if the discussion's getting out of control, we can, we can sort of maybe some of these things we can maybe put off till later or whatever. So, all right, so let's plug through this. So these were the topics that I had put down. So the first one is just a point that I want to make, which gets to some of the questions that you guys just asked about sort of the spectrum of immunodeficiency diseases that can cause autoimmunity, or can be associated with either autoimmunity or inflammatory disease. And do you guys know what I'm talking about when doctors talk about, or at least immunologists, when we talk about autoimmunity versus inflammation, do you have really any idea? Okay, so let me start there. That's a good place to start, all right? So, in general, when we talk about inflammation, that's stuff that, in my mind at least, the way that I think about it is that inflammation is, fevers, like when you get a sliver in your hand, it gets hot, it gets red, it gets inflamed, it might even get some pus there. That's inflammation. That's not autoimmunity. That's just your inflammatory cells, and these are some of the basic parts of your immune system that is part of your immune system that we call the innate part, kind of the part that you're born with, that moves in and it's eating up the bacteria and it's forming pus and those sorts of things. That's inflammation. When we think about autoimmunity, what we're thinking about is things like autoantibodies against things. So if you're making antibodies against like your blood cells so that you're getting autoimmune hemolytic anemia, or ITP is another one, immune thrombocytopenic purpura. That's an autoimmune disease, which is usually mediated by an autoantibody that your immune system's made. And it seems crazy, right? That if your immune system doesn't work to protect you from infections, why the heck can it work so well to cause problems? And right? It's really a puzzle. And so and it really kind of boils down to that's why we've kind of change the name a little bit to immune dysregulation. Basically, the immune system's not doing what it's supposed to do, but it's doing stuff that it shouldn't do. And it's because it's confused sometimes, or it's getting incorrect signals, or it's getting too much signal. And we'll talk about each of those in just a little bit, okay? So that does that make sense, the difference between autoimmunity? Yeah, another thing, somebody asked about T-cell infiltration into organs. So that's more of I think of that kind of an autoimmune sort of problem, where the T-cells are confused and they're beginning to attack you. And that's different than inflammation. Now, when they move into that organ, they may draw in some of the cells that are involved in an inflammatory response, and they can cause, inflammation as well. But the T cells attacking is more of an autoimmune process. So when I think of sort of T cells and B cells attacking stuff as autoimmune, and the other side of your immune system, the complement system, the phagocytes, the neutrophils, that they cause inflammation. Does that make sense? Kind of? Okay. So inflammation you can think of as hot, red, pussy, pain. That's inflammation. Autoimmunity is more mediated by autoantibodies, those sorts of things. All right, so, and then we'll talk about just the fact that autoimmunity is more commonly recognized in PID. We've mentioned that just a little bit, and then we'll talk about some specific autoimmune problems that patients with PID are particularly at risk for. Okay, so that's sort of what I've got, and we can go as far as we and stop at any point. So here's how I think about the immune system, sort of a simple construct of the immune system. Okay. So this, you can kind of break it into 4 compartments, and this is actually how I teach our residents and our fellows how they should think about the immune system too, and my patients. So kind of 4 major compartments, and you can kind of think of this as your military that protects your homeland, your body, from being invaded by things like terrorists, viruses, and bacteria that want to come in and take you over, right? So this is this is your immune military here, right? And just like our military in this country that has Army, Navy, Air Force, Marines, there's different divisions of our military. And if one of those divisions is missing, so assume in our military here in this country, if we were missing the Air Force, we would be at risk for being attacked by airplanes from the air, right? So that would be a problem. So it's the same in the immune system. If you're missing one division or one division is not working right, then you're susceptible to certain types of infections, and it turns out you're susceptible to certain types of autoimmune disease or autoinflammatory disease as well. Okay? Now, one of the things that we know is that there's a lot of connections. So the four major compartments here are the complement system, okay? And the complement is, I think, of sort of the landmines of your immune system. It's sort of waiting around. These are proteins that are floating around in the liquid part of your blood, in the plasma, just waiting for organisms like bacteria to come on and trip on those. And then there's a series of activation events like landmines, and then there's an explosion at the end that explodes the bacteria, all right? And it can also, if the complement system gets confused and starts to attack our own cells, it can also explode our own cells. And so that can cause types of autoimmunity. Okay, so that's the complement system. The phagocytes are really the Marines of the immune system, okay? The military. Like the Marines, you've seen those commercials, the Marines crawling through the mud to the battle, right? So like the Marines, the phagocytes, they crawl through the tissues to the side of the battle. And most of the Marines I know are really hungry. They've got big appetites. So these guys, they go out and they eat and eat and eat. And then sort of like a drunk Marine, they throw up on themselves, okay? So, sounds really gross, I know. However, you won't forget phagocytes, right? So, these are the neutrophils and the monocytes, okay? If you look at your CBC, your differential, when you get those labs, the neutrophils and monocytes are sort of what we think about here, okay? So again, they go out, they crawl through the tissues, they eat and eat and eat, and they throw up on themselves. And they do that so that they can show their friends, these other immune cells, they can show them what they've just eaten as they've been out there trafficking around in the tissues, right? So what happens is they go out into the tissues, they eat and eat and eat, they throw up pieces of what they've just eaten on their cell surface, and then they go back to a lymph node and they sort of sit there and wait. The lymph nodes are just like the singles bar of the immune system, right? So this is where immune cells like come in and they meet each other. There's a lot of snuggling, and anyway, there's a lot of interaction between those immune cells, and that's where these phagocytes who've been out eating stuff, they now have on their surface pieces of what they've eaten, and they're showing all their friends, hey, I was crawling out through the liver and I ran into this. I need some help attacking this. And so it recruits other immune cells to now go out there and help in the battle. Okay? So those are the phagocytes. The B cells, they're really kind of like the Air Force of the military. Their job is to make and deploy these smart bomb, cruise missile-like proteins called antibodies or immunoglobulin. Okay? So your B cells don't work. Obviously, you get IVIG or subcutaneous IG, but immunoglobulin replacement, and we're just giving you back the antibodies that the B cells should have been making, but they're not working like they're supposed to, right? So that's that. And then lastly are the T cells, which are really the generals, the assassins, and the psychologists of the immune system, right? So that's what they do. And so among those, there's generals who sort of like give direction to the other immune cells. And then there's the psychologists that are really important that basically say, you know what, you guys, you other immune cells, we had that viral infection last week. You did a great job fighting off that viral infection, but it's gone now, so take it easy, settle down, go to the spleen, meet a nice B cell, this is what they do. Take a vacation. So those are what we call the regulatory T cells, and they play a really important role in preventing autoimmune disease. And we've learned a lot about these cells over the years. Okay, so that's sort of the spectrum of this. Now, it may have been evident that with all of those different tasks, just like in the military, there needs to be a lot of communication between the different divisions in order to be efficient at fighting things off. But in addition, there's a lot of communication between those in terms of controlling one another and maintaining control of these immune responses. So if you think about it, we kind of ask the immune system to do an impossible task. That is, that our immune system has been asked to fight off any possible infection that it could ever see. Okay? But at the same time, we also ask our immune system to not attack us. And that seems like it's sort of contradictory. We want it to attack everything, but not attack us. And so it's kind of a weird contradiction. And so it's not surprising that it's easy for the immune system to get confused and start to attack us. And it turns out that there's lots of interconnections between all of these different compartments, okay? And so, fragments of the complement proteins actually, some of the complement protein fragments actually play a role in preventing autoimmune disease by sort of clearing out garbage that maybe the B cells or T cells would have reacted to if that garbage was left to hang around. And when I talk about garbage, I'm talking about like our own cells that are dying, constantly. We have cells that are made and they die, and when they die, they have to go somewhere, or all of that garbage just hangs around, and that can create a problem for the other immune cells to look at that and go, hey, wait a minute, if garbage is hanging around, it must be garbage, I better react to it, and that has the potential to cause autoimmune disease. And so the complement and the phagocytes, they play a really important role, for instance, in taking out the garbage, getting rid of all that junk that we create in our bodies every day, just by normal living. And so there's all these interactions between these different compartments, and I've put behind this a net. And the way that I kind of conceptually think about this is that you can imagine kind of a trapeze artist, that has a net underneath them. And they're doing their thing, and then they land on the net, and the net sort of bounces. But because of all of the connections between all of the different parts of the net, it bounces for a little bit, and then it kind of comes back to being stable, what we call homeostasis. It sort of stops bouncing, and then and then you're fine. But you can imagine that if you had that net, and you now went in and you just decided to cut a few holes in that net, that could create some problems. And now what may happen is either the trapeze artist may fall on the net and may just fall through, or may fall on the net and the net may start to bounce and go, sort of out of control, and then, it sort of bounces out of control and throws the trapeze artist off, maybe. So, and that happens because the connection, all of the interconnectedness is broken, and it's the same thing in the immune system. And the point that I would like to make, and that really the take home, is that defects in any one of these four major compartments, or in their ability to talk to one another, can lead to autoimmune disease. And what that means is that all of you sitting here represent patients who have probably defects in all of these different compartments. We had questions about complement, people who have B cell problems and are on immunoglobulin replacement. So we used to think that, that the problems that patient had were mainly infections. And, once we got better antibiotics and immunoglobulin replacement and were able to treat patients' infections more effectively, then we started to see all of these autoimmune problems emerging in patients. And so the initial takeaway would be is that it doesn't really matter which compartment of the immune system you've got problems in. There is a higher risk for autoimmune disease in any of these compartments, okay? So as a whole, immunodeficiency diseases are associated with a higher rate of autoimmune disease, okay? So that's sort of the first point that I think I would just make. And it's been more commonly recognized. I just wanted to, when we talk about these immune dysregulation disorders, I guess it makes sense to sort of define. So we've sort of defined it as a clinical disorder in which the normal mechanisms of maintaining immune homeostasis, okay, or balance, they're either missing or they're overwhelmed, leading to an inappropriate immune response that causes damage to the host in the forms of autoimmunity or inflammation. All right, so let me just show you an example. So this is common variable immunodeficiency. This is one of two studies that have been published. This study was published by Charlotte Cunningham-Rundles. The second study was published by Helen Chappell in the UK. And the bottom line here is this. So they went back through their charts of all of the patients. So this is Charlotte, and so this is at Mount Sinai. There were about 240 patient charts evaluated in this study. They went back through those charts and looked at what percentage of patients who'd been diagnosed with CVID had just had infections, and what percentage had more than infections. So these autoimmune problems, the inflammatory problems, And then what sorts of autoimmunity and inflammatory problems did patients have who'd been diagnosed with CVID, okay? Which is it's really a clinical diagnosis we use some labs to make the diagnosis, but there's not like a CVID test per se, right? So this was what they came up with. Now, the percentages here refer to the survival at 40 years. So on this axis, so you've got years, okay, here. So this is over 40 years, and then this is the percentage of patients that are surviving. So this is the survival curve. And what this really highlighted, and what was pointed out by the other study was done, is that yes, about between 30 and 40% of patients with CVID have other problems, either autoimmunity or inflammatory problems. So 30 to 40% if you've got CVID. And that if you've got certain types of autoimmunity or inflammatory problems, and they highlighted GI disease that causes malabsorption, liver disease or hepatitis, and then lung disease, and then lymphomas, obviously, in patients, those were associated with a much worse long-term survival in patients who have CVID. In other words, if you've got all of these other complications, if you just have the infections, then long-term survival is no different than the general population if you're on IVIG replacement and antibiotics and those sorts of things. It's exactly the same. If you've got these other inflammatory complications, then it puts you at risk for having lots of other problems. And so this really highlighted the need to focus more effort and look in more detail at what's going on in patients who have these other things. So it really highlighted. Now, to sort of add to that, when the diagnostic guidelines for CVID were revised in 2014, these are the European Society of Immunodeficiency Diagnostic Guidelines, which I think are really good for diagnosing CVID. And it's sort of like a, kind of a Chinese menu sort of approach. You have one at the top, and one of those, and one of those. At least one of the following is how you do it. So this is how we make a clinical diagnosis of CVID in the clinic, okay? But I just want you to note a couple of things. These were added when these revised guidelines. So now, one of the following. So in fact, if you have one of the following, you don't even have to have infections now to make a diagnosis of CVID.
That was going to be a question I had for you, because in my case, I never get measles. Touch wood, I don't get any infection.
Yeah.
I never had pneumonia or sinusitis or anything. I have all these other
Yep.
stories going.
Yeah, and so that's exactly right, and that sort of as we looked at patients who had been diagnosed with CVID, who had low antibody levels, for instance, we realized that not everybody gets infections. That in fact some patients have primarily autoimmune disease, and that's why these autoimmune or inflammatory criteria, the granulomatous lung disease, for instance, the lymphoproliferation, which means just big lymph nodes, and I'll show you some other examples of that. An autoimmunity can be a major feature. So you don't even necessarily need to have infections now to make a diagnosis of CVID. Now you have to have some of these other things to go along with it, but that's one thing that I think has been it signals the change in the field, I would say. That it's not just all about infections anymore. That autoimmune disease and inflammation is recognized as one of the major features. Okay, so that's the first thing. The second thing that was added in this criteria, and we can talk a little bit more about this, is this what's called low switch memory B cells. So there's a test that we do to look at the B cells in patients, and to look at how the B cells mature and develop, and we now look at look at that in all of our patients with CVID actually, and it's been associated now. It's been linked with abnormalities in that have been linked with CVID and other immunodeficiencies. So we use that as an additional criteria to make the diagnosis and to justify to insurance companies why a patient maybe needs to be on immunoglobulin replacement therapy. It's another sort of just initial thing. So those are the things that were sort of added to these criteria that I think signal kind of the change in this field, recognizing these complications of autoimmune disease in patients. Yes?
Does T cell have to do with the bone marrow and yellow and red bone marrow transitions back and forth?
The T cells or the B cells?
Yeah. In other words,
Mm.
or whatever.
Mm.
Does that have to do with the T cells?
So it can, so the T cells, so that can impact whether or not you have T cells and B cells in sufficient numbers, for sure, to be able to control infections. Yeah. So okay, so this sort of highlights this idea that autoimmunity, and then we now know, sort of on the right-hand side, on the left-hand side are sort of the organs, and of course infections and things. But on the right-hand side, all of the different types of sort of organ-specific autoimmunity that we see, for instance, in patients with CVID. We see autoimmune thyroid disease. We see the granulomatous lung disease. Many of you, I'm sure, probably have that. A few that I've talked to have mentioned that. Big spleen, big lymph nodes, which is just lymphoproliferation or overgrowth of the lymphocytes, certain types of the white blood cells, et cetera, and lots of GI issues in patients. Yes? I'm sorry, one more. Gynecological issues. So there's a couple of things that we see in patients related to gynecologic issues. One of them is there are absolutely some patients who develop gonadal insufficiency because of an autoimmune process. So basically, either ovarian failure in some females. Sometimes that can be related to an autoimmune process. Which we see sometimes. And then the other thing that was mentioned in terms of the mucocutaneous candidiasis, which some patients struggle with, not only can you get the candida, the yeast infections in your mouth and your esophagus, vaginal yeast can be a real problem in some patients. And of course, then a lot of times if you've got a lot of infections, you're on a lot of antibiotics. That just makes that problem worse. And so that there's multiple things actually that can affect that.
When you say ovarian failure, could it be the cyst or?
So it's not so much cystic disease that we see. That's sort of, I think, probably separate from this. It's more that because of an autoimmune process affecting the endocrine parts of the gonadal either development or maintenance is what gets attacked in an autoimmune process. And so basically the estrogen gets low, and basically the ovaries just sort of shrivel up and are not able to support then sort of ongoing development. So that we see, and we can see that in both males and females with gonadal failure. There's certain types of immunodeficiency diseases where that's more common than others, but that can be mediated by an autoimmune process as well in some patients. Not always, but it certainly can be.
Would you say like infertility in general? Like, say like you do ovulate, but you can't carry pregnancy kind of thing?
So there's multiple reasons for that, but there's certainly one part of that is certainly immune mediated. There's a subset of those that are probably immune mediated. Some of them are thought to be mediated by the mother's immune system attacking the sperm or the fetus that has the male's genetic material and markers in it. Because remember that the baby is half mom, half dad, so is only half matched to mom. And if we were to take, for instance, someone who is only half matched to you and inject some of their white blood cells into your bloodstream, you heard from Dr. Cohn today about bone marrow transplant and how we have to give conditioning chemotherapy to knock down the immune system that's there so the new one can come in. But if you don't do that, if you just put them in, what happens is your immune system just attacks that and wipes it out. And so it's really quite a miracle that a mom can actually carry a baby that's only half matched to her, because otherwise your immune system should reject that. So there's mechanisms in place to prevent that, but those mechanisms are not always perfect, and so that can be rejected in sort of an immune-mediated process.
Some of the regulation, autoimmunity that there dysregulate the hormonal incidence of women menstruating?
So that's a great question. So it's hard for us to separate it. So there's two things. So yes, it's possible that could happen. But the other thing is that we see in general in women who are ill, who have either chronic infections or who show up sick with other sort of severe sort of illnesses, that the menstrual cycle can be dramatically affected by that. They may actually stop menstruating for a while. It's kind of almost think of it as sort of hibernation mode. Basically, you're repurposing those resources that would have gone into menstruating into supporting other organs that need to be rebuilt and those sorts of things. So it's hard for us to sometimes to sort out, what could be mediated by an immune process versus what's just there because people are sick. So that, in terms of the menstruation, that can be more complicated. So, okay. All right, let me step across. So this is a busy slide, and I only put this here just to sort of let you know that so we just had a meeting about this among immunologists, and this was sort of what we came, and we kind of decided that these diseases, there's really a universe of these immune dysregulation disorders within the field of immunodeficiency. And you may recognize on this some things that some of you had. So some of them, the defects that I think about as debris defects, these are complement deficiencies or phagocyte defects like CGD, chronic granulomatous disease. Hemophagocytosis, or HLH, some of you may have heard about that. Patients who've got autoinflammatory syndromes, inflammatory bowel disease, rheumatologic disease, all of them sort of fit in this picture of immune dysregulation. So it's really broadened our view of this field, and this kind of gives you, this is more to just give you a sense for, well, there will be a test on this at the end, but no, I'm just kidding. There won't be. No, this is really to just give you a sense for kind of where the field is going. This I think, within the immunodeficiency field, this is now it's not probably yet sort of half of what people talk about at meetings, but it's getting there. So this is really sort of the other side of the coin of the infections and all the other things that we talk about at immunodeficiency meetings, which is why we felt that we needed to have a session about it here. Yes?
Just as a rheumatologist, how do you test for lupus in patients with CVID?
Oh, good question. Yeah. So lupus has, there's again, we love these diagnostic criteria, these Chinese menu sorts of approaches to make a clinical diagnosis. And lupus has 11 diagnostic criteria. And you need to have 4 of those to be able to make the diagnosis. Now, what you raise is the point that, in fact, if you've got CVID, you may not be making great antibodies, and so one of the criteria is that you have an positive ANA test, which is an antibody test. I will tell you, however, it turns out that, getting back to that weird conundrum that we talked about at the beginning, you may not make antibodies to infections, but you might make an ANA, actually, which doesn't make a lot of sense as to why your immune system would do that terrible thing to you, but we see it. So you can still make the diagnosis, and actually it turns out that most of the diagnostic criteria for making that diagnosis don't involve antibodies. They're clinical criteria like rash, arthritis, other organ inflammation, those sorts of things, which you can make the diagnosis without having to rely on the antibody tests. Does that make sense? So, okay, all right. So this is just to sort of give you a spectrum. So, and this is again, just to make one more point, which is, this morning in my talk we talked about genetic testing, and I know there is interest in talking about that here, and we do these genetic tests, and some patients who come to my clinic. So let me just give you an example. So there are patients who come to my clinic who come because they've been diagnosed clinically with a disease like what we call IPEX. So a lot of autoimmune disease, gut disease, rash, maybe some endocrine problems like type 1 diabetes. And we do the gene sequencing, and it turns out that maybe we find a mutation in the STAT1 protein that we might call a STAT1 gain of function mutation. Okay? But also patients who present with CVID can have a STAT1 gain of function mutation. And patients who present with ALPS, which is another type of immunodeficiency, these genetic defects, so for instance, CTLA-4 haploinsufficiency that some of you may have heard of, you may have even been tested for it. Some of you in this room may have been tested for it. I know that at least one of you has been. Patients with CTLA-4 deficiency, they can have the clinical symptoms of CVID, or they might have the clinical symptoms of ALPS, autoimmune lymphoproliferative disease, or they might have the clinical symptoms of IPEX. They all have the exact same gene defect, but their clinical presentation is subtly different. And so what it sort of led us to understanding is that, in this era of genetics, sometimes the gene is actually more important than the clinical diagnosis. And what it means is that sometimes we give you this clinical diagnosis of CVID because we don't know all of the genes yet, but then once we find the genes, we start to go back and then we can group people together by the gene defect that we see, and then we can start to understand, actually, though, the patients with CTLA-4 haploinsufficiency actually are a little bit different than the rest of the CVID population, and that kind of sets them apart, for instance. Yes?
Can you do genetic testing on somebody on IVIG?
Yes. Great question. It gets back to one of the questions over here earlier. So the question is, can you do genetic testing on someone in IVIG? Absolutely you can. And the reason for that is that in the IVIG, there's really no genetic material from the donors of all of that. What they do is they take the plasma, and normally in plasma there is some circulating DNA. But they take the plasma and it undergoes a number of purification steps, a number of treatments to get rid of any infectious organisms that may be there before it ever gets to you to get back. So all of the genetic material should pretty much be gone from that. So if we draw, even if you're getting IVIG, if we draw your blood, we're going to be getting the DNA out of all of the cells that have nucleus in your blood. So those are going to be all of the lymphocytes and the neutrophils and all. So it'll still be your DNA that we're testing, because the IVIG is just the protein. So absolutely you can do genetic testing when you are on IVIG. Now, sometimes, we even do genetic testing in patients who've had a bone marrow transplant. Sometimes patients get a bone marrow transplant before we even know a genetic diagnosis. They're really sick. They get a bone marrow transplant. The problem is when you do a bone marrow transplant, you replace all of their blood cells with the donor cells. So if you draw the blood and do a genetic test on that, you're just testing the donor. So what we do is we actually, for the patients who've had bone marrow transplants, we take a brush and we scrub the inside of their cheek and do buccal cells, so that we can get those cells, which aren't from the bone marrow donor. Or what we can do is you can actually just pluck some hairs, like when you're plucking your eyebrows, just drop those in a tube, and we can actually just take the little hair follicles and do DNA testing on those, because those wouldn't have come from the donor either. So we have tricks, we have ways to be able to do genetic testing, even to get around some of these other things, other treatments and things that people are on. So, okay, does that make sense? There's a question back here.
How common is a bone marrow or stem cell transplant in pediatric patients that don't actually have a diagnosis or any genetic disorders?
So the question is, how common is a bone marrow transplant in patients who don't have a specific genetic diagnosis? So I won't say that it's common. However, it certainly happens. And so, one of the places, so now many of you've heard at this meeting, and we'll hear, I'm sure, more about, for instance, newborn screening for severe combined immunodeficiency that's being done. So now that we've been doing that, it turns out that there's around 15% of those patients that are identified by newborn screening that have SCID. Basically, they have no T cells. They have they meet all of the immunology criteria for SCID, but we can't find a genetic cause in those patients. So those patients, because their immune system is proven to just not protect them, we have to do the bone marrow transplant before we know the genetic cause in some of those patients, because we have to provide them with a new immune system. So that's one place, for instance, where we do that. But in patients who have diseases that you guys are here in this room to talk about, so patients who have bad autoimmune disease, bad immune dysregulation, so maybe they've got really bad lung inflammation and that's causing chronic lung disease and other things, we do sometimes do a bone marrow transplant if other therapies that we've tried don't work. And so we've definitely taken now a fair number of patients to transplant who have these sorts of diseases. They've got really bad autoimmune disease, lots of inflammatory disease that we have not been able to control with other therapies. And usually we end up trying a bunch of different therapies before we sort of get to this point and say, throw our hands up and say, we just can't find anything that will stop this process. And if we can't stop this process, then there's going to be so much organ damage that there would be a risk for an early death. Then those patients are the ones where we talk about maybe a bone marrow transplant. And the hard part of that is that, first of all, we have to be fairly certain that just replacing their immune system, because remember with the bone marrow transplant, the only thing you replace is their blood cells. You don't replace anything else. And so you have to be pretty sure that if you replace just their blood cells, that's actually going to make them better. And some of these diseases have effects both on blood cells and on other cells like gut cells and other things. And so it gets tricky if we don't know the gene. So that's one thing. And then the other thing is, if we don't know the gene, it's hard to sort of give people an idea about what the risks of the bone marrow transplant are and what the chances of survival are. But sometimes we do it because we are out of other options. And it's kind of a last-ditch effort to try and control this severe autoimmune or autoinflammatory disease before it shortens their life, basically, is the idea. So we do definitely take patients. I wouldn't say there's a lot, but we definitely, a couple of times a year we have patients who we take to bone marrow transplant who meet those kind of criteria. So does that make sense? And a lot of these diseases, are curable by bone marrow transplant. But I think the point of this slide really was just to highlight that sometimes you may go around this room and find out that there are people here who have CTLA-4 haploinsufficiency, for instance, and some of you got to the immunologist because you had a diagnosis of CVID, and some of you got there because you had a diagnosis of ALPS, for instance. So the gene, though, once you've got a gene, then you can actually think about maybe drugs that really target that particular gene defect and make a huge difference. Okay, and we'll talk a little bit about that if we have some time at the end. Yeah. Yes.
Tell me what ALPS is.
Oh yes. So ALPS is autoimmune lymphoproliferative disease, and those patients they tend to have problems. So the most common clinical features that they have are typically enlarged lymph nodes and spleen. And then they have recurrent episodes. Initially, they're recurrent episodes, and then they can become chronic, of typically autoimmune cytopenias. And what I mean by that is autoimmune hemolytic anemia or autoimmune thrombocytopenia like ITP. Those are the two most common ones. And that's the classic sort of, with ALPS, those are the clinical features. So big lymph nodes, big spleen, and then recurrent autoimmune problems with depleting their red blood cells and their platelets mostly.
Obviously you've heard a little bit from me. I fall into this category, but I haven't had my spleen removed, but I'm sure they're going to broach, my hematologist will broach it at some point, but my immunologist has said not to remove it at this point.
Yeah, so great question. So the question is, how common is it in immunodeficient patients or in CVID patients to remove the spleen? And the hematologists in patients who've got ITP or low platelets, autoimmune platelet destruction, or autoimmune hemolytic anemia, the red blood cell destruction, the hematologists like to do splenectomies. And there are patients who just have that. They don't have any other problems. You can actually get, sometimes the classic thing for the autoimmune platelet problems in sort of pediatric patients, and it happens in adults too, is that you get sort of a respiratory infection, typically a viral respiratory tract infection, like a cold or a flu. And then probably what happens is your immune system makes a reaction to that then cross-reacts and attacks the platelets. And so what we typically see in pediatric patients is that they'll get a viral respiratory tract infection, then they'll present with these autoimmune platelet problems with ITP. And typically you treat them and that sort of goes away ultimately. And that's sort of the classic just ITP in kids. Most of those patients don't have an immune deficiency. Their immune system got confused for a little while, but you sort of treat that and then it kind of goes away in most patients. Then there are patients who have ongoing problems and come back over and over, as you know well. And so in those patients who don't respond to sort of the typical therapies of steroids, right now at least in the hematology literature, their next kind of big step, they try steroids and some immune suppression. Their next step is to take out the spleen, even before they deplete the B cells. So some people get rituximab as a way to deplete the B cells. We'll talk about this in a couple of minutes here, but rituximab is this drug that you can give to actually just get rid of the B cells. The whole idea being that, if the B cells aren't doing you any good anyway, they're not protecting you against infections, you're on IVIG, let's just give them rituximab and get rid of the B cells that could be causing problems. So unfortunately, the hematologists, their algorithm is kind of an old-fashioned algorithm, which is that you do steroids, and then you do some other immunosuppressants like MMF or maybe methotrexate or something like that. And if those don't work, then they take out the spleen. That's sort of their algorithm. Instead of like saying, well, let's the problem is you only get one spleen. Usually, most people, once you take it out, it's gone. So it's not really reversible. Whereas the rituximab, your B cells, it makes your B cells disappear for a year or two, but ultimately, most people, they come back. The B cells come back. So it's not a permanent, thing that you've done. But their old algorithms are just, they go to splenectomy early. Now, the risk that we worry about splenectomies in our patients because, the spleen is a kind of a big filtration unit. And it sits in your circulation. So your blood circulates back through the spleen and kind of filters through the spleen. And the spleen has all these little, it's literally almost like a strainer. The blood kind of percolates through it, and it sort of pulls out. Your spleen is just absolutely full of immune cells. And so if you get bacteria in your bloodstream, which you can do just by brushing your teeth in the morning, or eating something that's hard and you gouge your gums, or maybe you pick a scab and you get some bacteria in your bloodstream. Those circulate around, they get caught in this filter unit in your spleen, and they get eaten and they're taken care of. If you don't have a spleen, then it puts you at risk for having, in patients who've got normal immune systems otherwise, they can usually deal with that okay. If you have a sort of one hit to your immune system, that's okay. Their immune systems are working okay otherwise. In an immunodeficient patient who's already got some holes in their immune system, now you add one more big gaping hole in the immune system, and the risks of getting then a severe infection because of a bloodstream infection go up substantially. And there's not great data on it in our population, but we definitely have seen patients who have their spleens out, and maybe they then get tired of taking their prophylactic amoxicillin, which is what we put them on, or their primary care doc says, "Oh, you don't need to take that," and they don't take it, and suddenly they come in with sepsis, which is a bloodstream infection, or they don't get immunized.
Or the doctors forget to tell them, and then they get like meningitis.
Yes. Yeah, precisely.
Get the information out so they can get their shot.
Yes, precisely. So that's so we try to avoid splenectomies in most of our patients. Now, at times we can't, and I have a little gal who's got CVID. We don't know her genetic cause, but her spleen was so enormous that she couldn't actually. She was losing weight because she couldn't eat. It was just basically filling her whole abdomen almost. And we tried a number of drugs to try and shrink it, and just could not find anything that would shrink it down. We ended up with her doing a splenectomy just so she could eat. But she was. I knew her for a long time. She was very vigilant about taking her prophylactic antibiotics, and she's done okay with it. But it makes us nervous in patients who've got otherwise have problems with their immune system. And I would much rather start with maybe using rituximab, for instance, before going to jumping to splenectomy. There are cases where we can't avoid it. It's kind of a last-ditch effort to try and control autoimmune cytopenias, particularly the ITP or autoimmune hemolytic anemia. But anyway, does that make sense? Yeah. Okay. We doing okay so far? Okay. All right. So there was a question over here about which autoimmune diseases people are with PID are susceptible to. So let me run through some of these. And so these are the organs that I was just going to touch base on. So probably within the immunodeficiency realm, the most common autoimmune disease that we see in patients with CVID and a lot of these other disorders that I mentioned, it probably kind of goes in this order. So hematologic autoimmunity. So this AIHA, that's autoimmune hemolytic anemia. That's your red blood cells being attacked. Okay. ITP is immune thrombocytopenic purpura. That is your platelets being attacked with an autoimmune process. So those are probably the top, and those have been estimated in about 40% of patients with CVID, that at some time in the course of disease, patients will have one of those if you carry a diagnosis, a clinical diagnosis of CVID. Okay? GI disease is probably the next most common that we see, and a lot of patients have GI issues with a variety of different immunodeficiencies. And then in the lungs, LIP is lymphocytic interstitial pneumonitis. Sorry, there's all these acronyms. I apologize. It's job security for us, Otherwise, anyway, I apologize for all of the acronyms. But basically, what it is it's infiltration, and I'll show you some pictures of this in a minute. It's infiltration of the lungs with lymphocytes. You asked about T cells in organs. This is one of those places where the T cells and B cells can go where they in numbers that shouldn't be there. And I'll show you some pictures of what that looks like. The skin, of course, a lot of people have skin issues. Eczema, psoriasis is common. Those sorts of things can be really problematic for some patients. And then endocrine problems. Those are the ones I was going to touch on. Now, as you mentioned, there are other organs, of course, the autonomic stuff that I didn't put on here and other things. So let's just walk through these real quick. I wanted to just start with the heme. So most of the patients who've got these hematology problems, so autoimmune hemolytic anemia, thrombocytopenia, most of these problems with blood counts. I mean, you can have problems because your bone marrow just kind of poops out and stops working. We do see that. It's kind of, you can kind of think about your blood counts. It's kind of like a bathtub in a way. You've got you've got a drain that's draining at a certain rate, and you've got the faucet on, and it's filling at a certain rate. And so the faucet is the bone marrow. It's putting out blood cells at a certain rate, right? And sometimes if you get, certain things will make it increase the rate at which it puts out blood cells, okay? And then the drain is really the destruction. And sometimes cells get old and they get taken up in the spleen, the strainer, right? Taken up in the spleen and gotten rid of. But you can really open up the drain and decrease and really dramatically increase the destruction rate if you make an autoantibody against those blood cells. So if you make an autoantibody against red blood cells, it sticks to those red blood cells. The complement sees that, it attacks it, and it explodes the red blood cells. Red blood cells gone. So that's like basically taking your bathtub and just making the drain huge, right? Everything just drains, and then suddenly you've got to really, increase the input. And now the faucet comes from, your physicians who are giving you back blood cells, if transfusions or other things you may need. And so most of the time in our diseases, there are some patients who develop bone marrow problems where the faucet just kind of dribbles, turns off eventually, where their bone marrow kind of fails. But most patients just have problems with autoimmune disease. Okay? And so the way that people treat that is with steroids. These are sort of some of the therapies. So the old standbys are steroids, cyclophosphamide. So some of these other immunosuppressant drugs, MMF, Cellcept, I'll throw a few names out there, methotrexate. You may have heard of a lot of these that people use. Those are kind of the old standbys, and then high-dose IVIG. They kind of give you not just the doses that you get to prevent infections, but like really high doses to try and swamp the system and prevent the autoantibodies from causing such big problems. Okay? So those are the old standbys. But over the last several years, there have been really more and more drugs that sort of target, or ways of sort of targeting B cells and antibodies. And the one that I would just was going to highlight, because you may have heard about it from your doctors, is rituximab. Has anybody here had rituximab? Have you?
Evaluated for it last week.
Okay. Okay. So. Oh, okay. All right. I thought it'd be worthwhile maybe mentioning what rituximab is. You may have heard your doctors talking about rituximab. I put all of these on here because there's a number of different drugs now that target the B cells, but rituximab is the one that we've got probably the most experience with. So one of the things that you need to know is that the B cells, they're born in the bone marrow as baby B cells, and then they begin to mature like humans, and then you get sort of elementary school B cells, and junior high school B cells, and then high school B cells, and then fully adult B cells out here. And it's the fully adult B cells that are the ones that are producing the antibodies, something that we call plasma cells, and they're antibody factories is what they are, and they just churn out bucket loads of antibodies. That's their job. And they're one of the fully mature adult type B cells, all right? So that's how the B cells develop. Now, it turns out that rituximab is this anti-CD20 thing. Okay, so it's an antibody, actually, that people have made that targets this protein that's on the surface of B cells. The rituximab sticks to the B cell, and then what happens is the complement system then attaches to that rituximab antibody that's on the B cell, and it blows up the B cells. It just explodes them and gets rid of them, okay? So it depletes the B cells, but you'll notice here with the black box, you'll notice that it only knocks out sort of the elementary, junior high school, and high school age B cells. It doesn't knock out the adult B cells who are actually making the autoantibodies that are causing your problems. Okay? And what that means is that these cells, some of them, you have to sort of wait for these cells to sort of die off. And it can take a little while. Let me show you some data. So in some studies that were done, so this is a study where they looked at ITP, one of the things we've been talking about, so the autoimmune platelet problems. And there were a number of small studies. And so one of the tricks that clinical researchers use to sort of get better statistical validation of something is what they'll do is they'll go to the literature and they'll take a bunch of small clinical studies and they'll aggregate all of those patients together from those different clinical studies, and then they'll redo the statistics on the whole group. And the challenge of that is that not all of the clinical studies were done exactly the same way, so you kind of have to make some assumptions. So that's what this is. That sort of a study is called a meta-analysis. They basically go back and just search the literature, find anything that looks relevant, and then they just aggregate them all together and reanalyze the data. That's what they do. So that's what they did here. And the important thing that you need to know, so in the end, there were 19 studies that were included in this that included 123 patients with ITP. Okay? They treated them with rituximab, and the important things that you want to see are here. So the time to response in weeks, so this is the time to start seeing the platelet counts bouncing back up. This is the median, which means right in the middle, 5.5 weeks. Okay? Because again, the rituximab doesn't actually knock out those really mature B cells that are actually making the antibody that's causing the problems. And you have to wait for those to kind of go away, and then, you knock out the ones that are the junior high school and high school age ones so that they can't grow up and fill in and continue to cause this problem. That's how it works. Yes?
But do you keep the patient on steroids?
So you keep them on whatever it takes to keep their platelet counts in a range that's safe. Yeah. In the meantime. So here, there, and there. So here.
I was looking at the plasma cells, and I had a bone marrow biopsy, and the only thing that came back is showing an abnormal plasma cell. Could that be an autoantibody then?
Probably not an autoantibody. That's probably related to your underlying disease process. So CVID, it's not that uncommon. So in CVID patients, we see sometimes low plasma cells. That's the problem, is that you've got CVID because you're not able to make any of those cells that are supposed to be making antibody. So when they're absent, it's probably related to like a CVID sort of picture. So back here and then.
What would you say is safe platelet count for child?
So a safe platelet count for child. So there's a little bit of debate, but I'll tell you what our criteria are for our patients. So for instance, for our inpatients, most of the time we will consider giving a transfusion if they're below 20,000. In some patients, if it looks like they might sort of be able to, they might be on the rebound and they might be able to make some of their own, we'll let it drift down a little below that. But when you get below 20,000, I think there is data to suggest that the risk for abnormal bleeding goes up. So, but our transfusion threshold for most of our patients is around 20,000. Now, if you're a patient with Wiskott-Aldrich syndrome, which is an immunodeficiency that has a platelet problem, sometimes we'll let those patients drift a little bit lower. But anyway, that's usually where we think about kind of at least thinking about a transfusion in those patients. Does that make sense? Question up here, yes.
It's kind of a simple question. Just curiosity reasons. My son was treated with on steroids for a long time. Now we're after a year of being treated, so we can finally start weaning him.
Yeah.
But after your previous slide where you're showing that the retux doesn't really affect the mature cells, is that why with plasmapheresis not necessarily work for someone that the retux works for?
Good question. So let's go back to this. So it's a really good question. So let me just explain what plasma. The question is, can you also use plasmapheresis? So let me explain what some of these other things are. So plasmapheresis is it's an exchange, sort of a plasma exchange. So basically, what you do is you put in a couple of IVs, and the blood comes out one IV. It goes through a system that basically pulls off the patient plasma, and then you replace it with donor plasma going in on the other side. And the idea here is that if you've got a lot of circulating autoantibodies that are there circulating, causing problems, you suck them off, basically. And you can decrease the levels of those. And so you can absolutely combine plasmapheresis with rituximab. If a patient has an autoantibody-mediated process that is really aggressive and they're in trouble, then you can absolutely do that. Because the way that I've got this sort of here is that these are kind of different compartments of the B cells. So you've got the developing B cells, you've got the mature B cells that are churning out the antibody, and then you've got the antibody, which is in the liquid plasma part of the blood. And so you can actually target each of these compartments. If you're systematic about it, you can kind of target them each individually. And so you can do rituximab to knock those guys out. The problem is it's going to be a while before these circulating antibodies go away. So you can get rid of those faster by sucking them off. Okay? You can do plasmapheresis to suck those off. You can give IVIG back to swamp them out. That's one thing that we've mentioned. And there is one drug which is not used broadly in our community, in the immunodeficiency community, which is actually a drug that's used in patients with a certain type of cancer, multiple myeloma. Multiple myeloma is a cancer of plasma cells. They get a cancer that's made of plasma cells, and so they make lots and lots of antibody, abnormal antibody. It doesn't work. It's no good. So they designed this drug called bortezomib, and it's really the only drug on the market that actually knocks out plasma cells. So we, in a couple of severe cases, we've used a combination of these. We knock out the teenage B cells here, we knock out the plasma cells with bortezomib, and we do plasmapheresis. If a patient's really in bad clinical shape, and we know that it's mediated by an autoantibody. But again, what you're doing is you're sort of tackling each compartment individually. And it seems like a lot, but it makes sense when you think about it mechanistically like this.
Well, it totally makes sense because one of the things that we're seeing with our son and many patients I know who are being treated for the same thing is after that first rituximab infusion, they feel like crap.
Yeah.
Right? They feel terrible, and I'm wondering if that's because this is still remaining.
Well, partly. Plus, the fact is that you're basically destroying a bunch of immune cells that are full of all sorts of interesting things that cause inflammation, and so you bust all those open, and all that stuff gets released, and so it's not surprising that people feel kind of prone.
Does this go faster though? Like I think about our situation, and it took about 6 months to really see some results. Would it go faster using those two things, or doing something with it, or no?
So it can go faster, yeah. So if you use the plasmapheresis and bortezomib along with the rituximab, you can get things. you can control things faster. The problem is, as you add more of these, of course, there's risks associated with each of them. And with bortezomib, for instance, there's a neuropathy that happens in about 20% of patients where they get a peripheral neuropathy, and it doesn't always correct after you stop the drug. But again, in patients who need that, who are in trouble, it's available. And a lot of people don't think about it because it's not sort of in our. People haven't added it to their toolboxes yet, but it is out there. There will be more therapies that attack plasma cells, but it kind of makes sense that if you really want to stop a process now, you need to kill the cells that are actually making the antibodies, and then you need to get rid of the antibodies that are circulating. So, makes sense? Yes. You don't. That's a great question. So you don't. So what we do is we give them back regular plasma from normal individuals, and those then go back in. And at times we supplement with some additional IVIG in what they get back. So unfortunately, we don't have any way to differentiate between the bad ones and the good ones. It just all comes out. I think of it, this is in a way, it's not quite sort of back to the old days of, where they used to use leeches and things like that to suck out, bad humors, but, it's close. Anyway, sort of like the modern leech, I guess is what I think of it. So anyway, but you're absolutely right. So that means that in an immunodeficient patient, sometimes we do actually give them IVIG back with the plasma that gets replaced. Because you suck out their plasma and give them plasma back from them. Okay. Yes. Yes. So great question. So the question is C3 nephritic factor, which is a complement disorder, but it's actually an autoimmune complement disorder. So it's not actually a genetic complement disorder, we don't think. It's actually an autoimmune one that causes this autoantibody that causes problems with the complement system. And so you can get infections. Absolutely. Normal. Yeah.
And they're like, if we give you rituximab, it's going to kill you.
Well, it won't kill you.
They were not saying, they were not go for it. Although it might fix the problem, they don't know if it's good enough. Have you had any research or anything with that?
So it's a great question. So people are using it for C3 nephritic factor. Okay. They're using rituximab for C3 nephritic factor. Again, it's an autoantibody-mediated process. And so if you can get rid of that autoantibody, they're all anecdotal. There's no big there's no big clinical studies of this yet, but people are using it for C3 nephritic factor. And you raise the point that your B cells are a little dodgy. So and it raises this point that it's an autoantibody. And I'm not surprised that your B cells are a little dodgy because probably you shouldn't be making autoantibodies. So there's something that's causing you to make autoantibodies, which may be that your B cells are a little dodgy. So it could be that you haven't. Well, there you go. So so again, it's sort of an underlying immunodeficiency that gets then an autoimmune disease that causes another immunodeficiency. I mean, it's like art imitates life, which imitates art. Anyway. So it's exactly so. Yes. So people are using rituximab. Although what I would say is just this: there are patients, and we think that that many of these patients probably have an underlying immunodeficiency. There are patients who get rituximab, which again, it's supposed to get rid of sort of the elementary, junior, high school B cells. But they get rituximab and their B cells never come back. And there are some small case series that have estimated as high as 5% of patients who get rituximab for certain indications can do this. But sort of the hypothesis is that the people whose B cells don't come back, probably those are folks who have an underlying immunodeficiency. They get autoimmune disease. Their immunodeficiency is not diagnosed, but they're seeing somebody for their autoimmunity. They get rituximab, and now their B cells, which weren't quite working right maybe in the first place, which is why they got autoimmunity, just never come back. So I would say there is a chance that if you were to get rituximab, it would probably take care of the C3 nephritic factor, but there would be a risk maybe that your B cells may not come back.
They said they were going to hold off for a while.
Yeah, and so anyway, but again, you have to sort of weigh the balance of what are risks and benefits to each of these therapies. And one of the beautiful things about rituximab is that it is very targeted. It's, unlike steroids that you pour them in and they affect everything. They affect bone cells and, they make you crave salt. And so you want to eat those, you want to eat all the, the salty things, and that makes you retain water and you gain weight. I mean, it's just terrible. Rituximab is very targeted. It takes out the B cells. We know exactly what it does. We can give IVIG back to cover the immune deficit that we create. And so in general, we like it because it's so targeted. That's, yes.
So what happens if your B cells don't come back after rituximab?
So if your B cells don't come back after rituximab, then you would need to probably stay on IVIG or IgG replacement for the rest of your life. And if you're already on it for your whole life, what's the loss, right? So and this is sort of this is our thinking. I mean, if your B cells are doing things that, number one, they're not doing what they're supposed to do. They're not protecting you, and they're creating problems. I think rituximab and immunodeficiency is a match made in heaven. Actually, I think that patients with X-linked A gamma globulinemia, some of the people at this meeting, they live without B cells for their entire life and get IgG replacement. And yes, they're at somewhat increased risk of some other infections, but generally they do very well. They grow up and become physicians and lawyers and car mechanics and, do all of the things that people do. So it's, it's expensive to do that, I guess, when you look at it. But in terms of just the health-wise, in an immunodeficient patient where the B cells are already not doing their job, there's not, and they're already on IVIG, there's not a lot of, you don't lose a lot by giving rituximab, and you potentially gain.
How long do you feel that people need to do the rituximab for, or is it different between each disease?
Good question. So how long do people do rituximab? So generally when you give rituximab in someone who doesn't have an underlying immunodeficiency, so kind of in the general population that just happens to get autoimmune disease for some reason, the B cells stay away. The B cell numbers drop. So if we draw blood and look at B cells, the B cell numbers drop to 0, and they stay at 0 on average for about 1 year, plus or minus, a few months, and then they start to slowly come back. And in some autoantibody-mediated diseases, as soon as they start to come back, we start to see a recurrence of the symptoms, and we end up giving another course of rituximab. There are some patients where we give a course of rituximab, the B cells go away, and we sort of watch carefully as their B cell numbers are coming back in, and they don't develop the autoimmune disease again. Somehow the rituximab depleted the bad B cells, and the ones that are coming back in weren't confused, and they were okay. So it varies by patient, but in general, people have advocated that if you give rituximab, you can just watch the B cell numbers. And if it's somebody, if we've sort of given a patient a try of letting their B cells come back and they get autoimmune disease again every time, we just don't give them a chance. We sort of, at a year, the instant we start seeing those B cells come back, and it's usually about once a year, we give them another round of rituximab and redeplete them. So is how we do it. And but sometimes we let them come back, and they come back, and we sort of bite our fingernails, and we watch and wait, and the autoimmune disease doesn't come back with it. But anyway. It varies from patient to patient. Here and there and there and then there. So, yes?
So, in my case, I've been on high-dose steroids for nearly a year now.
Mm-hmm.
Does that affect my B cell production? So when I start rituximab, maybe it's not able to do its job because I don't have enough B cells in my system. Anyway.
So the question is, if you've been on high-dose steroids and maybe other immunosuppressants for a prolonged period of time, does that affect your B cell production? It does. However, the rituximab will still work. What I would actually anticipate would be the opposite, which is that you may be one of those folks whose B cells don't come back for a very long time because of all the other immunosuppression that you've been on. Your B cells may actually, post-rituximab, not come back for maybe ever, or your risk for that would be increased because of all the other immunosuppression that you've received. Okay, does that make sense? So maybe the opposite of what you're actually thinking is it. So from a therapeutic standpoint, it's great. 1 round of rituximab, and you may be good for a while. But the steroids definitely have a big effect on B cell development, and can even knock your B cell numbers down a little bit. There's a question back here, and then back in the corner. Yes.
I was
Mm-hmm.
And anyway, I ended up not because of the situation, and circumstances unexpected. At the last minute, I was dropped out of the study. I got sick. Anyway, everybody that was in that study, they did stimulate their B cells, but they couldn't turn them off.
Ah.
And they all died from different cancers.
Yeah.
Lymphoma.
Yes. Yeah.
What a
Yeah.
it was
And
funny before it happened.
yeah.
You know,
Yeah. And that's. Yeah. No. You raised an important point, which is that anything that can promote the growth of these cells, of B cells, for instance, does increase a risk for them sort of developing malignancy down the line. So, it's a tricky business, and we try to be very careful in patient selection and being really thoughtful about risks and benefits and those sorts of things before we use these. But you're absolutely right. It's you start and the challenge in patients with inflammatory diseases, and it's not just immunodeficiency disease. It's been looked at in things like rheumatoid arthritis and other diseases. Is that the incidence of malignancy, particularly lymphomas, is higher in patients who've got chronic inflammatory disease, and it makes sense really because. Remember that every time a cell divides, it has to duplicate its DNA. It has to make a copy of its DNA. And each time it makes a copy, there's a chance that it can make a mistake. And that mistake could be in a gene that's really important for cell growth, that it maybe turns that gene on and makes the cells now begin to grow out of control. In cancer, they call these oncogenes. You may have heard that name. And it turns on the growth of the cell. And so within inflammation drives division and growth of immune cells. And every time a cell divides, there's this risk. And so the more times your cells divide in your lifetime, it increases your risk of having a mistake. And so that's why chronic inflammation is not, it's why we feel like we need to deal with this, is that it increases not just your risk for feeling crummy, but it increases your lifetime risk for other things like cancer and things like that. So, does that make sense? There's a question back here.
I just wanted to ask about conditions where you see deficiencies or dysregulation in T cells.
Great question. So, we haven't really touched on those much yet, but absolutely. So, deficiencies or dysregulation in T cells, one of the challenges that remember T cells, they're sort of, like I said, they're the generals, the assassins, and the psychologists of the immune system. And so, because they're the generals, if the T cells are dysregulated, in other words, they get abnormal, they sort of respond abnormally to cues that they get, they can drive, because they're the generals, they've got the ability to sort of direct the immune response. They can drive B cells to do abnormal things, like make autoantibodies and things like that. So that's one place that T cells can go haywire. They get dysregulated because they've got abnormal function in some way. And some of the genetic causes of disease that we see in immunodeficient patients cause the T cells to do exactly that, to sort of respond abnormally to normal cues that they get. They get a normal cue, but their response to it is abnormal because they've got a mutation in one particular protein that affects how that B cell then, or how that T cell then does its thing. So it sends the wrong message then. So that's one thing. The second thing is because one subset of the T cells are these regulatory T cells, if those regulatory T cells are affected in their development or their function, remember they're sort of the psychologists, and we know, so in patients who've got a complete absence of regulatory T cells, that immunodeficiency disease is called IPEX syndrome. And so these kids, these are boys, it's an X-linked disease, so boys, and in the absence of regulatory T cells, they actually develop autoimmune disease in utero while they're developing. And then they have severe autoimmunity really as infants typically, and it can be life-threatening if you don't treat it aggressively after they're born. So that's what happens in the complete absence of regulatory T cells. But say you've just got maybe the regulatory T cells are there, but they just don't quite work right, which is one of the things that we think happens in, for instance, CTLA-4 haploinsufficiency that we've talked about a little bit. It's one of these diseases that we see in patients with CVID and other things. The regulatory T cells use this protein CTLA-4 to sort of help them suppress and control the other cells. And if it's only half as much CTLA-4 there as should be there, then they're not as efficient at their ability to do that. And what happens is the immune cells just grow like crazy because they're not getting turned off. And so you see lots of, you see big lymph nodes, big spleens, the overgrowth. I'll show you a picture of this, overgrowth of lymphocytes in the gut and in the lungs and other places, because the regulatory T cells can't shut them down. They just don't have the tools to do that. So, does that make sense? Yeah. Yes, question here.
This is really basic.
Yeah.
What buzzwords, I've gone to like a dozen different doctors, what buzzwords do I get somebody at Kaiser to pay attention and check what they should check?
So I think, if you, so it varies by disease, the things that sort of will get the insurance companies to sort of trigger something. But in terms of your physicians or the insurance companies, one of the things, so for instance, if you have CVID and you have the bowel disease or you have the liver disease, we'll just send them that picture that I showed you earlier from that paper from Charlotte Cunningham Rundles that basically shows that if you have those, 40-year survival was 42%. And you can just tell them, look, this is going to be a big problem if I don't get appropriate therapy and don't get an appropriate diagnosis. And so we sometimes forward those papers along with the request for these things. And usually it takes multiple rounds of fighting with the medical directors and on. But there's getting to be enough data around this now that you can sort of support it. So in CVID, the critical things were that led to a poor long-term outcome were gut disease, liver disease, lung disease. Those were the biggies. And it's very clearly laid out. Actually, the way that Charlotte wrote the paper, it's very clearly laid out that those increase the risk for a bad outcome. For other diseases, it varies a little bit by disease, but we sort of, the things that sort of get the insurance companies attention are things that are going to lead to them spending more money on you in the long run if you're not appropriately diagnosed and treated, I guess is how I think about that. And so we call out those things. If they don't want to pay for IVIG, I very clearly lay it out in my letter. I say, this patient has low immunoglobulins. They are at increased risk of infection. And I actually have this thing. So if I end up talking to a medical director, the first thing I do when I get on with them, I say, tell me your name again. And then I write it down, Dr. Smith, whatever. And they say, well, we just can't approve that. It's not one of the approved indications and everything. I said, well, the patient's got low IgG levels and they're having all these infections. I really think it'd be, my professional opinion is that it would be beneficial. They say, oh, no, we can't pay for that. And I said, okay, I just want you to know that this patient's proven that they are having recurrent infections. Those could be life-threatening. I just want you to know that I've recorded your name in their medical chart so that when the patient gets an infection and dies, their family can sue both you and me. And they usually go, no, don't put my name in the chart. And I said, oh, it's too late. It's already there. And they say, well, let's talk about this. Okay, maybe we could do a 3-month trial, and you just keep track of how well they do. But, sometimes you have to kind of play hardball. So anyway.
I'm dealing directly with doctors.
Yeah,
It's Kaiser.
sure. Yeah. So you need to find an advocate who's willing to advocate on your behalf.
Yeah, because the doctor will listen.
Yeah. So you need to find an advocate who's willing to advocate on your behalf. And I think, again, and a lot of allergists who don't do a lot of immune deficiency may not be familiar with the literature. And so, for instance, if you have CVID and these complications, take them the paper. Say, read this, educate them. Or invite them to call someone who's got more expertise and get sort of filled in. Or ask for a second opinion somewhere. And go somewhere and get a second opinion with this all laid out. So.
But how do you get them to diagnose? He has but her health care is fragmented.
Mm-hmm.
And say if it's Kaiser,
Yeah.
somebody that put it together and say,
Yeah.
maybe.
Yeah, it's difficult. So what you might say is just, I'm assuming that I'm probably costing you a lot of money. Wouldn't it be better if we got a firm diagnosis and we could get on the appropriate therapy that would maybe be better? How about if we ask for a second opinion, and maybe I could fly to New York and see Charlotte Cunningham Rundles and get a second opinion, or go, and because, honestly, for the insurance company, the cost of that is not much, really, to do that. And if you can go someplace and get a second opinion where they sort of lay out in detail, this is what I think you should do, then that can be very beneficial, both for you and for your physicians. Because in all honesty, I think my experience has been a lot of times, physicians it's not that they don't want to help you find a diagnosis, they just may not have the expertise to know how to go about it. And I think that sometimes asking for that is really helpful. Tara, you guys have a...
Yeah, I was going to say, if you can convince one of your physicians to use the Immune Deficiency Program, Foundation Consulting Immunologist Program. I don't know if Troy's a part of that, but we have a lot of our medical advisory committee serve, they serve as expert immunologists, just for this case. So if somebody, and you can do it for free, it's a free program.
Yep.
So if they need some kind of second opinion or something like that, you can have them submit a consult online through the IDF.
Yeah.
And what is that called? Consulting Immunologist Program.
Yeah, and it's available. It's online. It's on the IDF website. It's there, and there's a number of us that do that. And basically we your physicians, typically the way that it works is the physicians will call us and sort of run through everything with us, or sometimes they forward us some records. We review those and then walk through it with them and make some suggestions about what to do. And those are all options. And I think, again, you have to remember that these the companies, the bottom line is, it's crazy as it sounds that, we have for-profit insurance companies, but, unfortunately they have to think about investors and all of these things. And so, remembering what hurts them is, what they answer to is money. And so, you can say, look, I've been to a bunch of different people here. I'm sure I'm costing you a fair amount of money. Wouldn't it be better to try and get a real diagnosis? Help me out with this, and try and convince someone to do that and take the next step. You kind of have to find an advocate, though, who's willing to work with you, and it can be difficult in a managed care organization where you've got, where you're more limited in what you can do. But just keep pushing, be aggressive. Just push, and you pay a lot of money to have that insurance. It is. It's terrible. Yeah. Yeah. Yeah, and that is a problem across the board these days. It's really hard. But I would get to an immunologist, or allergist immunologist. Start there and push hard. Push. Yes.
What's been your experience with Bcells, long-term Bcells for T-cell dysregulation?
Great question. How about if we get there in just a minute? Would that be okay? I actually have some slides about that, just a little bit. Yeah. So let me get. So before we move there, any more questions about the B-cell issues? No. We got tons of time. So all right. So I brought this with the ITP. So just to sort of make the point even more with rituximab, just sort of finish this off. So this is another autoantibody-mediated disease, a skin disease called pemphigus. You have blistering skin disease, but it's caused by an autoantibody. In this disease, the mean time to complete remission, 5.8 months after rituximab. Okay, so again, it can be a while after rituximab. So that's sort of, we've killed the rituximab, beat that horse to death. All right, here we go. GI disease, enteropathy, liver disease. Okay, so a lot of patients with immune deficiency have this sort of a problem in their GI tract, and all of these little pearls here that you see that are just completely studding this colon are aggregates of lymphocytes, all aggregated together. And this is what's called a lymphocytic colitis, and some of you may have been diagnosed with this. And this is just the lymphocytes going bananas. They've just overgrown. It causes, anywhere where those lymphocytes are, you're not absorbing anything, number one. Number two, they're secreting all sorts of nifty stuff that's making it so the rest of your bowel is not working so great either. Okay, so Sometimes steroids can work and things like that. So one of the things to remember about GI disease is it tends to fall into a couple of categories. There's that sort of inflammatory kind. This gets back to that sort of idea about inflammatory versus autoimmune. There's the inflammatory kind of bowel disease, which is usually, it's an angry, bloody diarrhea. So you go in and you do the GI doc does the endoscopy and takes biopsies, and even sometimes when they bump up against the mucosa with the endoscope, it actually will bleed because it's just so, the mucosa of the bowel is so angry and what we call friable. It's just delicate and it just breaks apart easily because of just all of the inflammation that's there. Okay? That is compared to autoimmune enteropathy, which is what we see in a lot of patients with CVID and CTLA-4 haploinsufficiency and STAT1 gain of function, STAT3 gain of function, all these sorts of diseases that we see. In which case, these patients typically just have profuse watery diarrhea. And it's watery because of the picture that I just showed you. You've got all these inflammatory infiltrates. It's not angry, inflamed, but you don't absorb, and so it all just goes through. So profuse watery diarrhea, villus atrophy, those are all of the villi are the little fingers that are projections on the inside of the mucosa that are meant there to sort of absorb lots of the fluid. What happens if you get inflammation is those sort of go away, and now the bowel kind of becomes flat, and the absorption goes way down. So that happens, and sometimes autoantibodies can actually target some of the specific immune cells. And these patients, so this is what we see often is CVID, for instance. This is what we see in patients, for instance, with chronic granulomatous disease, NEMO deficiency, CAP deficiency, those sorts of things. XLA patients, we see more this kind of inflammatory angry. And what it means is that, in terms of getting a diagnosis, one of the things that I find really helpful in patients where we don't know the genetic cause is actually getting some tissue, getting a biopsy from the bowel and looking what are the cells that are actually there, because the cells can really help me to sort of think about, is it more this or is it more this when you pair it with sort of the clinical picture. And it can also help you think about what would be the drugs that I would start with. Do I start with drugs that more affect the T cells and B cells over here? Or do I start with drugs that might affect more the inflammatory cells, things like steroids or a TNF inhibitor, for instance, here. Over there, I might use something like we could use rituximab potentially in some of those patients, but more commonly a drug called rapamycin that is a T-cell directed drug that sort of quiets T cells down. So again, clues. We just, in the absence of a genetic defect, we have to get clues from wherever we can get them, and sometimes biopsies can be really helpful with that. Here and here, yes?
Yes, I have the lymphoid hyperplasia, and how I was diagnosed 35 years ago, colonoscopy. But anyway, when I have problems with vomiting when I get, and we have a terrible time sometimes getting under control.
Yeah.
But anyway, I guess what I want to know, is there a reason that would cause that nausea and the vomiting?
Yeah, I mean, if your bowel is inflamed and it's got a lot of stuff, the bowel needs to. It starts at the top and it squeezes all the way down and through in these peristaltic waves. And so if it's inflamed and angry, then those waves don't always move forward like they're supposed to. They won't always sort of start and move their way through. Things back up, and your bowel doesn't like things backing up. And so you put stuff in, and either has to come out the top or it has to go out the bottom. And if it doesn't go out the bottom, then it's so that's what happens. So if your bowel is sort of irritated, then the peristalsis, those waves of peristalsis, don't work quite as well. So it can definitely happen. Yeah. Yeah, absolutely. So controlling the inflammation is really helpful in those cases. There was a question here, and then I'll come back. Yeah.
So on the biopsy, it shows eosinophils and the lamina propria.
Yep. Mm-hmm. Yep.
Is that related to?
So these tend to have more eosinophils in them. Sometimes we see eosinophils there, but usually the eosinophils are involved in sort of this more inflammatory sort of colitis. A lot of times, not always, but a lot of times that's where we see that. And it's not that unusual to see some eosinophils in these inflammatory GI diseases. Some eosinophils, some are very eosinophil rich, and that makes you think of maybe some different therapies even than ones we might use here. But a lot of times they're there, but they're not there in huge numbers. So, question here?
You mentioned diarrhea. What about the opposite?
Constipation. Yeah. So, constipation is a little more difficult, but what I would say is that we definitely see patients who fluctuate between the two. So who may have a week of just profuse watery diarrhea, and then they fluctuate the other way, and they're like totally stopped up for a week. And so, it's the fluctuations that make me think that something could be going on. Chronic constipation by itself, I don't necessarily think of as necessarily being a GI problem, but if patients are going from profuse watery diarrhea to constipation and then back to profuse watery, back and forth, that makes me think that there could be something going on. And we see this occasionally in patients with just inflammatory bowel disease that they will do that. Fluctuate back and forth. Yes.
So our son has CVID, or cellular.
Yeah, sure. Yeah, sure. I understand. Yeah.
But he's old enough now that we don't know what his bowel habits are, but
Yeah.
we know that he complains of horrible stomach aches
Yeah.
frequently.
Mm-hmm.
So, and trying to get him to talk
Yeah.
about, as a pediatric immunologist, what do you do? How do you get them to understand that this communication, we need to know?
Yeah, it's.
People want to know gross stuff.
Yeah, yeah. No, sometimes we do. No, just so sometimes it's really difficult, and it's really difficult in it starts usually around 7 or 8 and goes up through the time that they're about 15, most of the time, somewhere in that range. Some kids are, it's up to 12 or 13 range. They don't like to talk about poop and pee and those sorts of. I mean, they like to talk about it, but not, among their friends, not, but not with their doctor or their parents. So, so it's hard. So the things that we do is we monitor weight carefully and look for them falling off the growth curve as they're growing. We monitor sometimes nutrition labs, so we'll look at albumin levels, sort of as a general measure of protein, because sometimes they just won't tell us, and sometimes the story that we get when we actually ask them to poop in a cup in clinic, what we see is different than the story we get from them. So that's the other thing is you can have the doctor ask them to poop in a cup in clinic, and so we give them a hat and they go in the bathroom and then you can actually look at it and see. So if there's you come up with some stool study that you need to send, but there are ways to sort of get at that, but it doesn't get at it every day. But it's a challenge, and so we do use these other measures to try and give us an idea of what's going on because it's difficult in that stretch. Especially with boys. Girls are more open, as always, but boys are difficult. So that's my suggestions. Monitor weight, monitor diet. One of the things I would say is that. It was really brought to mind in one of my older IPEX kids, who hadn't gotten a bone marrow transplant yet, and he told me that he, and this only came about because he was having terrible electrolyte problems, and we were trying to figure out what was going on, and he ultimately confessed to me that if he drank anything after 5 p.m. at night, he would have an accident in his bed. By this time, he was a teenager, and so he'd figured out how to manage this, which was just to not drink anything after 5 p.m. And so he, as a result, he'd actually wound up in electrolyte imbalance. His electrolytes were off, all out of whack because he wasn't drinking enough. He was, and his kidneys were starting to have issues. And so, monitor diet as much as you can. Sometimes you can't always monitor all the intake, but kind of keep track. That's another way you can kind of, if there's weird, quirky things about their diet that they're doing, or that can be sometimes an additional clue. So I wish I had, we need a crystal ball, a parent crystal ball. Yeah. Yeah, no. It's totally common. Yeah. So it's difficult. Let's see how we're doing here. Okay. So let's let's chunk along here. I'm going to chunk along. I want to just show you a couple of things that I think we really need to get to. Did anybody have lungs that look like this? This is what's known as granulomatous lymphocytic interstitial lung disease. So this is not a normal lung CT, if you're just wondering. So all of these white things shouldn't be there. Those are either granulomas or they're aggregates of immune cells. Okay? And when you look at them closely, if you zoom in with a microscope, if you do a lung biopsy and zoom in, the lung should look like this. It should have these little thin walled bubbles like this. All of this extra stuff in here should not be here. And one of the things about the lungs is that in patients with CVID, CTLA-4 haploinsufficiency, STAT3 gain of function, all those can have this. PI3 kinase defects can have this in the lungs, and CVID without a genetic diagnosis can have this, and this can be really problematic. Two things here we know. It used to be that we thought if we could just control the infections, we'd be fine. All that inflammation would go away, and patients wouldn't get chronic lung disease. That's not true. So if, in the old days, we would just give them more and more IgG. Well, the answer is more IgG. Well, we're not getting that many infections. I'm not actually getting all that many infections, but the lungs were still bad. Then we realized when you do the biopsies, these are just packed with immune cells. So they're packed. So what we see in these, actually, a lot of times, is that we see these aggregates of immune cells where there's B cells that are all clumped together like this, and they're surrounded by T cells like this. And it turns out that this sort of structure is exactly what is in your lymph nodes. Remember the singles bar where the immune cells go to meet one another? So it's this structure of B cells surrounded by T cells, that we call in immunology, we call that a lymphoid follicle. It's great. We want those in the lymph nodes where they're supposed to be. And it's a way that lymphocytes organize so that the B cells can talk to the T cells and the generals work together with the B cells to make an antibody response. Now the problem is if you have chronic inflammation in any organ in the body, this can happen. They begin to organize into these lymphoid follicle-like structures. And that lung is full of them. If we had taken this lung and stained it for B cells and T cells, you'd see little circles of aggregates of B cells surrounded by T cells through this. So this is what gave Jack Rudis the idea of let's deplete then, let's just get rid of all of those B cells, okay, with rituximab. And so you do that, it debulks the lungs, it gets rid of all of those B cells out of there, and then in addition he uses a T cell inhibitor, a drug that works on T cells, azathioprine, combines those together, and that can be really beneficial in patients who have this sort of lung disease. Yes?
So this kind of lung disease, in general, do you see these collections disappear and appear in other places? Because that's what, like my lungs don't look as bad as that,
Mm-hmm.
but I have, let's say, 10 at any one time.
Yeah.
But 6 months later, I'll have another scan, and it's...
They'll be different places, yeah.
And there's a little bit of a memory of it, but
Yep.
they're all in different places.
Yep, absolutely.
Typical, or...
Yeah, pretty typical. Yeah, pretty typical. They can show up in different places, and we can see these in the. And I'll show you a picture in the gut in just a second where that's there. And so that's the idea is you use rituximab to deplete the B cells out, and then the T cells go away too. And sometimes in patients whose lungs are just full of B cells, you use rituximab, and suddenly your breathing gets dramatically better over the course of like a week.
Does it heal?
Yeah. Yes. However, if we don't control the inflammation, so what we know now, if you have lung disease like this, if you've got CVID, controlling the infections by itself is not enough. You have to control the infections and you have to control the inflammation. And if you don't, you get chronic lung disease, which is scarring of the airways, and something called bronchiectasis, which is scarring and sort of your airways get kind of floppy and they don't work as well. And so if you let this go on over time, you get progressive scarring, and then if you give rituximab, it'll get rid of what B cells are there, but it won't heal because basically it's all scar tissue now and it doesn't respond. So treating early is important, and keeping them depleted, and then if there's not a lot of scarring and you do it, yes, it heals. It does. It heals and gets better, and you do better. Yes.
What was the name of the second medicine?
azathioprine. So, and this is published. Jack Rutis, Ruotes, has published this protocol. And within the immunodeficiency community, it's pretty well accepted in patients who've got this sort of an approach. Yes?
Can you only diagnose this through biopsy?
So, good question. So what we know is that so pulmonary function tests, which many of you have probably had, you blow into the tube and all that stuff, are not sufficient to diagnose this. So a high-resolution CT scan of the chest is the first step, but we try to biopsy all of our patients because sometimes we've been surprised. Sometimes we do the biopsy and it looks like this, sort of the standard what we call granulomatous lymphocytic interstitial lung disease, GLILD. So sometimes it looks like this and there's B cells and T cells there and we know we give rituximab and we give azathioprine and it gets better. Sometimes we had one patient where we did the biopsy, there were no B cells in the lung. Her lungs were full of T cells. And so we said, well, we actually need to use a T cell inhibitor. We don't need to get rid of the B cells because the B cells aren't even there. We need to use a T cell inhibitor in her. So that's what we did in her is we gave a drug that shuts down T cells, a drug called tacrolimus, which shuts down T cells. And so that's how we tackle that. And it happens once or twice every year. We get a patient who comes in, an older patient typically, 50s and above, come in with this sort of a picture, being diagnosed with CVID. We do the biopsies, and lo and behold, it's a tumor. It's chronic lymphocytic leukemia is probably the most common we see. It's sort of a slow-burning tumor. And so that's why we try to do a lung biopsy on every patient. And so and the biopsies that, sometimes they'll try and do the biopsy, they'll do a bronchoscopy and go down through your airway and do a biopsy. That's not sufficient in most cases. It actually requires to actually get a piece of the lung from out in the periphery. And what it means is usually they can do it with a laparoscope and just go in and take a little wedge of lung. But that really we need, that's the most definitive way to make the diagnosis. So pairing chest CT, and I wouldn't do a lung biopsy. If I got a chest CT and it looked completely normal, I wouldn't think about a lung biopsy, but unless they were so short of breath and I couldn't explain it another way. But typically we do the CT, we see this, and then we go, okay, now we need to do the lung biopsy, find out what cells are there, and then we can target the therapy accordingly. Okay, again, getting back to the idea that tissue really helps sometimes, biopsy tissue. Okay, does that make sense? Okay, this is lungs. How are we doing? Ooh, we got 8 minutes. Okay, let's keep going. Oh yeah, this is a good one. Here, sorry, let me go back here. So this is from Jack's. This is the paper Jack published. You can look that up. So and here's a patient. Again, here was before treatment. Okay, and you see all these thistles that shouldn't be there. Okay, and then after treatment with rituximab and azathioprine, you look, all that white stuff goes away, and it looks much cleaner. And the patient felt a whole lot better. Okay, so that's the lungs. Let's talk about skin. We can sort of let's breeze past skin because I want to get to your question about T cell inhibition. Sorry. You want me to do skin? Okay, let's do skin. All right. So these are probably the most common skin diseases that we see in our patients: eczema, psoriasis, and pemphigus. Okay. All right. So those are probably the most common ones that we see in our patients. Now, eczema. There's a lot of ways to treat eczema. I will say for psoriasis, there are a growing number of drugs to treat psoriasis specifically that are on the market. And in patients who've got really bad disease, there are a growing number of options beyond the old-fashioned coal tar, steroids, those sorts of things. There are actually some new psoriasis drugs that actually work quite well. And these are common, again, because the immune system gets dysregulated. It doesn't work the way that it's supposed to, okay? And so, so what I would say is that it is very useful. If you've got skin disease that's really bothersome, it's very useful to get a referral to a dermatologist because they have all sorts of nifty tools. Number one, biopsy again. I know I keep saying this, but biopsies are really helpful because we can actually look at what immune cells are actually there. You have to stain the biopsies for the immune cells, but you can actually look at what cells are there and design your treatment accordingly. And sometimes again we get surprises. We had a patient who came in with CVID. We did a biopsy and it was a lymphoma. It was a cutaneous T-cell lymphoma that he had. It wasn't psoriasis at all. So again, biopsy material is again, it's helpful, and I know it's not pleasant, but it can be really helpful in being able to design a treatment course. That's all I was going to say about skin, other than just supportive care. I think, one of the things to remember about the skin is that nutrition is really important. And if you've had chronic GI disease, or your child has chronic GI disease with diarrhea, it's not that uncommon for them to become zinc deficient. And zinc deficiency can have a skin disease that looks like terrible eczema. And the problem is that no amount of immune suppression is really going to solve that underlying problem. You need to correct the zinc deficiency, for instance. So remember that there is a connection. And so if you make sure that nutritional support is good, you may need to work with a nutritionist, because it is important for skin. And then we use a lot of topical therapies with skin diseases as well. That's all I was going to say about the skin. Can we move on to the last thing now real quick? Okay, I just wanted to talk briefly about somebody had asked about abatacept, and I wanted to get back to this, and T-cell inhibition. So it turns out that for instance, within CVID, there are a growing number of genetic defects that cause CVID. And typically the patients where we're finding those genetic defects, it's not usually the patients who just have infections where we're finding those genetic defects. It's in the patients who've got the more complicated forms of CVID, the ones who've got autoimmunity, lung disease. In some series now, up to 35% of those patients now we're finding genetic causes of their disease in. So if you have the type of CVID with all of these autoimmune inflammatory complications, there's value in starting to think about doing genetic testing. In the old days, we didn't think about it so much in CVID because we didn't have any answers. We have some answers now. And so among those are, for instance, a disease called CTLA-4 haploinsufficiency. We've talked about it. I'm talking about it here because it leads us into abatacept therapy. Okay? So here's the deal with CTLA-4. So remember that I told you that the regulatory T cells are the psychologists of the immune system. And their job is to basically turn down other cells. And the way that they do this is like this. So up here, so here's the T cell down here. This is a T cell that's getting mad and angry. In order to get it mad and angry, there's a lot of control in how this gets done. So here's what we call an antigen-presenting cell. This is a phagocyte that's gone out there and it's eaten some stuff, and it's now thrown up part of what it's eaten on its cell surface. And so this brown thing here is part of what this phagocyte ate when it went out into the tissue. It ate it, it digested it down into a little piece, and it put it into this molecule on its surface called the MHC molecule. And now the T cell, the way that it recognizes this foreign thing, this is sort of like a hot dog and a hot dog bun. Here's the hot dog bun, here's the weenie here, right? So T cells love hot dogs, but they just won't even look at them if they're not in the hot dog bun, right? So here it is, it's in the hot dog bun. The APC said, it ate a big sausage, chewed it down into a cocktail weenie-sized piece, put that here in the hot dog bun. T cell comes along and says, ooh, that looks delicious. And its T cell receptors stick here. Okay, so that's signal one that goes into the T cell. That's not enough to get a T cell angry and mad yet. It requires other signals. And so it gets those other signals through these other molecules on the surface of the phagocyte called CD80 and CD86. They're there. They bind to this other molecule on the T cell called CD28. Now the T cell gets two signals and it says, okay, two signals. Now you've convinced me that this is something real that I need to respond to. And it starts to get angry. And it says, I want to get in the battle as one of the soldiers, okay? And then what happens is the antigen-presenting cell, or this phagocyte, it sends some cytokines, some growth factors, over to the T cell to basically just kick it in the pants and say, okay, go off and do your thing now. Go fight, right? So that's what it does, all right? Now, what happens is that there are these regulatory T cells that come along and they say, okay, you've done enough now. Settle down, for crying out loud. And the regulatory T cells come along and they have on their surface a T cell receptor. And then they have this molecule here that looks like a stop sign here called CTLA-4, okay? And it comes along and the T cell attaches here to the cocktail weenie and the hot dog bun, and it sees that and it says, okay, you're still angry and showing me all these things you've eaten out there, but we need to turn this off somehow, right? Because things are getting out of control. So CTLA-4 comes along, it binds to this same molecule here, and what it does is it actually strips it off the surface of that cell, like that. Whoop, gone. And now what happens is that this phagocyte, it can still show the cocktail weenies to the T cells, but it can't provide the second signal. And so it can't get T cells mad anymore. So it turns down inflammation and an immune response, right? And so this is what CTLA-4 does, is this. Now, the thing about abatacept, what abatacept is it's just CTLA-4. It's CTLA-4 attached to another piece of a protein. And so you put it in, and so what you do is you infuse it, and it sort of takes the place of the regulatory T cell to sort of convince those phagocytes to sort of cool it down, take it easy, stop activating so many T cells. So that's kind of how it works. Okay? So this is this drug called abatacept. And so in patients who have, let me go back here, in patients who have CTLA-4 haploinsufficiency, they've lost one copy of their CTLA-4, so they don't have half as much CTLA-4 as they should, they get all sorts of autoimmune disease, the things we've been talking about. Gut disease, low antibody levels, they get lung disease, like the ones we've been talking about. Here is a biopsy from the gut of a patient with CTLA-4 haploinsufficiency. These are the B cells. See the nice circle of B cells? And it's surrounded by T cells over here. You can see the T cells are just all around that. And so it's getting these aggregates of lymphocytes because, again, you can't turn off these cells that are promoting the lymphocytes to grow. They're saying, go, 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 fight, fight, fight. That's what the phagocytes are doing, but you can't turn them off effectively because you don't have enough CTLA-4 around. So what we do is we give CTLA-4 back with abatacept and do that. So here's abatacept. It comes in, it binds, and it takes the place of the regulatory T cells, and so that's how it works. Now, with abatacept, I don't know how long a patient could stay on abatacept as a way to sort of control T cell autoimmunity. There have been patients who've been on it for quite a while. Probably the thing that we've seen with abatacept in a subset of patients is and it's actually in the flyer with the drug, is it can, because you're turning down T cells, and T cells are sort of among the T cells are the assassins that are involved in sort of controlling viral infections. We do see EBV, that's Epstein-Barr virus, that's the kissing disease, that one, the monovirus. We do see reactivation of EBV in some patients who are chronically on abatacept. Not everybody, but it is one risk of sort of keeping the T cells sort of quieted down over the long run. Okay? Does that answer your question about abatacept? No. Yes? No? Do you have more questions about abatacept? No? Okay.
Not about abatacept, but the T cells that you mentioned that the assassins are the ones that kill off the virus.
Mm-hmm.
That's what our son is conditioning. So
how do you rev those up? Oh, good question. So the challenge, the challenge with revving up T cells, it gets back to the point that was brought up earlier about B cells. We get a little nervous about revving up T cells too much because we worry that we'll push them the other way and go from now not fighting off to viral infections to now push them to be too aggressive and start to cause autoimmune disease. So it's a real challenge, and I would say that there are no proven, well-studied mechanisms of necessarily revving up those sorts of responses. What we tend to do is, because the T cells are sort of the generals, they control the B cells and how they make antibodies and do all those things, we support them in other ways, but it doesn't directly get at this question of if they can't control viral infections. And sometimes those are patients that we end up taking to bone marrow transplant because the one way that we know that we can fix that T cell problem usually is just to replace the T cells. That's where knowing a genetic defect just becomes incredibly, incredibly helpful. And so digging, just in closing, I know we're really we're out of time, we're over time. Can I just one last couple of thoughts? There were questions. Some of the questions you had is, how do I get a diagnosis if I don't have one? And these are, we have better and better tools to make a diagnosis. As I mentioned before, you can do genetic testing. We can find a way to get material, even if, whatever happened. We can get material to do genetic testing on anybody. And we're getting enough genes that we know about that we can that it's worthwhile. I think especially like I said, if you've got any of these other sort of features, or say CVID with one of these other with all these other complications, it's worth the hit rate on finding a gene is actually reasonably high now in those. A third of patients. It's a third. But that's a third, and it's better than we had before. And the thing about it is we've certainly had the case where we did the sequencing on the patient, we did exome sequencing or genome sequencing like I talked about this morning. All of the data was there. We said, we don't see anything here that makes sense to us. Went to a meeting. At the meeting, somebody presented a new case that they thought was caused by a mutation in this particular gene. I said, holy cow, that sounds just like that patient. While I was sitting in the meeting, I got online, pulled up the exome sequencing that was on our server back at Children's, pulled up that gene, looked at it, and holy crap, there's the answer, there is value in doing the sequencing, even if you don't necessarily find an answer right now. And there will be also more and more data about therapeutic responses and risk for side effects of drugs that they can predict based on looking at your genome. So there is there's value in getting sequencing done if you can figure out how to get it paid for.
Will insurance cover genetic testing?
Yes and no. So insurance. So it's difficult to get insurance to cover genetic testing, certainly the full cost. So at our I run a lab, and at our lab, our reimbursement rate for genetic testing is about 30% from the insurance companies. That's about what they pay. So it's not great. So trying to get involved in research studies is one way to go. The other thing, just as a pearl. Sometimes the insurance companies are more, even if the cost of doing a gene panel, so now we've got these panels of genes, we can sequence all 320 immunodeficiency genes at once in a panel, but we only look at those genes versus like a whole exome or a whole genome. Sometimes even if the cost of the whole exome or whole genome is exactly the same as the panel, sometimes the insurance company will pay for the panel, but they won't pay for the whole exome or genome. And the reason for that is that when you do a whole exome or genome, they're supposed to also give you a list of 50 genes that have now been identified as being at risk for disease. So it's like BRCA1, so breast cancer risk, colon cancer risk, yada, yada, yada. And the problem is that the insurance company knows if you get all that data back, there's a certain percentage of the population that will end up going to have a mammogram, a colonoscopy, and while it's better care for the patients, it costs more money. And this is how, unfortunately, this is the situation we live in. So, one way around it, if your doctor's just saying, well, we should just go for an exome or a genome, the other way is to say, all right, let's bag the idea of an exome or genome for now. Maybe let's just try a panel and see if you can get them to go for a panel. There's some tricks you can use. You can persuade, and then there's a lot of us who are doing research and happy to try and work with patients. We're working on ways to try and working on a consortium to see if we can get some funding to try and do sequencing for patients who've applied for insurance but can't get coverage. So there's things in the works, and we're trying, but it is a challenge. It's going to get better. There will become a point where every child born will get a whole genome sequence done. It's not that far down the road, probably. They're piloting it now with the CDC, but it's maybe 10 years out at the most. So, but in the meantime, we have to figure out how to get it done other ways. So do that. The other thing I would say is get other information wherever you can. Biopsies, like I've said over and over, really important, of affected tissues. And then, B-cell phenotyping, T-cell phenotyping, just gather data from wherever you can gather it. Okay? We'll stop there. Sorry to keep you from your lunch a little bit.